Okay, so now regarding the diagnosis and management of acute graft versus host disease, we'll be going through this guideline, which regarding the summary of the guideline, there is just I think we'll go over it in the end. We just go through the introduction first. Now, the graft versus host disease, it means a major complication of hematopoietic stem cell transplantation, and the incidence of acute graft versus host disease is 10 to 80%. Okay, so this is depending upon the risk factors basically present. And the corticosteroids are effective in less than 50% of patients, and a number of novel agents have been developed and investigated, both as first line treatments and for management of steroid refractory disease. So basically, the incidence will vary depending upon the risk factors present, and the corticosteroids, they are effective in um, less than 50% of patients, which are basically used as a first line. But and a lot of other for steroid refractory cases, even cyclosporine and other calcineurin inhibitors have been used. And despite these developments, there is no consensus on the optimal strategy for managing this. Now, the Joint Committee is actually this guideline is actually divided into three documents, including this um, the this one about the acute graft versus host disease. Then there's also this document about chronic graft versus host disease, and then organ specific management and supportive care in graft versus host disease. So and these guidelines, they actually complement each other. So we'll be actually basically repeating a lot of things in all these guidelines, and we'll try to cover them together in 2 3 days. Now, the key the areas that have been covered in diagnosis and management of acute graft-versus-host disease are, first of all, the diagnosis, how to diagnose them, then grading, and then the first, second, and third line treatment agents. For in the organ specific management, they will go into the different organs involved, and then also the infection profile axis. Now, the methodology, I think this is just part of grading that they have done. And with regard to children, actually, the guidelines, they are applicable to both children and adults unless otherwise specified. Although there are certain conditions that are specific for children, but they will actually highlight them as they come along. And one such disease that they have not actually mentioned here, that is supposedly of greater incidence in children, is the it's a fact that veno-occlusive disease can be more frequent in children, basically because of the immature enzymes present and the immature the nature of the liver in these children. So that was one thing that I think we'll come across when we go into the liver toxicity. And otherwise, also the fact that most of the children who undergo transplant are for non-malignant disorders, and so they will. So in those cases, basically they will not benefit from the graft versus malignancy effect. That is some that although some try to actually they allow for this, so that they do not do a very stringent GVHD profile access, because they want to have this slight graft versus malignancy effect also. So this may have implications for the choice of GVHD therapy. So so in children mostly, the GVHD therapy can be modified, and so that because and especially when it's for non-malignant disorders, so they can have a more stringent, a more powerful GVHD profile access in these patients, because because we do not want this graft versus malignancy effect in most of the non-malignant disorders. So there will be a variety of comorbidities also. In children, they may not be. There will be comorbidities because of the underlying disease, and also treatment toxicities would be more. So all this would actually lead to the final choice of what kind of GVHD therapy they would be preferable in these patients. and in those children, and also what kind of treatment option would be available. For example, whether we want to more go for some steroid sparing therapies or otherwise. Now, the diagnosis of acute graft-versus-host disease is predominantly based on clinical findings and is often one of exclusion. So, mostly we will come across a quite differential diagnosis here also. Whenever we come across a differential diagnosis for graft-versus-host disease, there will be differential for other it is there will be a wide differential, as there may be infections involved, drug toxicities involved, and also other specific disorders. So that differential would depend upon whether we are considering more, whether um, uh, the presenting complaint is more of cutaneous symptoms or GI symptoms or hepatic symptoms. So the differential would slightly vary with that, but generally just viral infections and drug reactions and other engraftment syndromes and the effect of the, the chemotherapy or radiation that may have received as part of conditioning of the patient. This may affect um, this may affect the differential for the skin is the most common organ involved at the onset, and followed by GI and liver. And skin GVHD typically causes a maculopapular rash, which usually starts. We are going to start now first with the skin. Basically, presentation of what are the clinical features for skin disease, and also for what kind of differential they have then for GI, and then we'll go into the liver toxicity. And side by side, we'll be discussing some of the histopathological findings, and then the grading part of this. So this would be like regarding the diagnosis. So how we make the diagnosis for this. Now regarding the cutaneous manifestations, they usually start with a maculopapular rash, which usually starts on the palms and soles. So most of the mm, uh, so most of the symptoms involved would affect skin and skin of the palms and soles, and the areas that may be effective are also the face and the neck. So usually, generally, it starts with the palms and soles or the face and the neck, and then it can spread to involve the other areas of skin as well. And then there could be like a generalized. It is then usually to include the rest of the. Okay. So so now regarding the GI toxicity, now regarding the skin toxicity, it starts as a maculopapular rash, usually involving the palms and soles, but may commence in any part of the body. It may be in the face and the neck also, but then generally it will spread to include the rest of the body as well. In the most severe forms, a reaction similar to toxic epidermal necrolysis may occur with widespread skin involvement and mucocutaneous ulceration and bullae. So it generally starts with the maculopapular rash, but then it can also become a more. It can involve not only involve the rest of the body as well, but it can also become more toxic and severe as well. So then it may be similar to toxic epidermal necrolysis. In this case, now first there was just a rash, but then it can become ulcerated and bullous formation can occur, and then the skin may also become necrolyzed, and there would be peeling off of the skin. So the differential would include in this case. So if we go to the differentials here, this will be then the drug reactions, the viral exanthems, then engraftment syndrome, and the effect of chemotherapy or radiation. And the distribution is more of over the face, palms, and soles is more common, but it can occur. And this would the fact that this rash occurs along with this association with the hyperbilirubinemia and diarrhea would actually make GVHD a more likely differential. Otherwise, in drug reactions and viral exanthems and these effects of radiation or chemotherapy, there would be other associated features as well. Or in case of, like, for example, in drug reactions or viral exanthems, sometimes only the skin is involved. And so then regarding the cutaneous biopsies, these may be important, particularly in the absence of the classical constellation of symptoms. So if the classical symptoms don't occur, then it would be it would be advantages that we have these biopsies taken as well. And histological features would include, now the histological features, basically there will be a lot of apoptosis. Now the apoptosis in this case would occur even in the GI tract also. There will be a crypt based apoptosis in the in the base of the crypts. Here the apoptosis would be at the base of the epidermal retipex. So it's basically a sort of an interface keratitis with the at the part where the epidermis and dermis actually meet. At that part, there would not only be a basis apoptosis at the base of the epidermal retipex, but in the dermis also there would be there would be a perivascular lymphocytic infiltration, and this keratotic epidermal keratinocytes and would be seen. So basically, if you look at the skin would be like, if you had a skin, then this was the epidermal layer and this is the dermis. And in the dermis, there would be lymphocytic infiltrates, and in this epidermis, there would be a dyskeratotic epidermal keratinocytes, and in at this interface, at the junction between the dermis and the dermis, there would be um, uh, there would actually be this uh, apoptosis. And there will be a lot of apoptotic bodies at the junction. And this keratosis and this exocytus of lymphocytes and satellite lymphocytes adjacent to the this keratotic epidermal keratinocytes and perivascular lymphocytic infiltration. All these are histological findings. So basically, it's like in the dermis there's lymphocytic infiltrate, and in the epidermis there would be dyskeratosis of the keratinocytes. There would be epidermal keratinocytes, and then also we can differentiate this if we have like if you have like this which I can that as well. Um, skin GVHD. Okay, so I think I'll sort of try to make this image clear again, because I just lost this connection for a while. But we'll just continue, and probably I'll have some images ready next time. Okay, so now here we have this Okay, so I think this is clear again. Okay, and anyway, now this logical diagnosis, we were just going through this, and I will try to have some images ready for this. Next time, we were discussing the epidermal, the findings. That is, the epidermis would show apoptosis at the base of the epidermal retipex, and so there would be a dysclerotic changes in the epidermis, and in the dermis there will be infiltration by the lymphocytes. So these are basically, and at the interface, that is at the retipex where the dermis and the epidermis, they actually um, uh, um, they join. At that interface, there would be this apoptotic bodies. The rest of the epidermis would be dyskeratotic. Now, the cutaneous biopsies was not found to be useful in predicting the severity of the disease. Um, in and a retrospective study showed that there was poor correlation between the clinical severity of the skin rash and the biopsy findings. And they concluded that skin biopsy may have a limited role in the management. So the final decision analysis, concluded that in the allogenic stem cell transplantation group, the best outcomes would be obtained with treatment of GVHD and no skin biopsy. So instead of actually going for skin biopsies, they had concluded that the treatment should be initiated. And more recently, LFN, which has been found to be overexpressed in GVHD skin biopsies. So this was then used as a this was then used as a marker for and this have been found to be significantly higher at the onset of GVHD, and they correlate with the severe GVHD. So with the greater risk of death relative to other known factors. So this may have a prognostic value as a biomarker of skin GVHD. So basically, we have a role for cutaneous biopsies for diagnostic purposes. They may have this cutaneous biopsies, but now an upcoming role has been that of plasma levels of ilafen. And this is probably, I think, a skin biomarker. This is used and this up is ilafen was Silicon is actually a peptide. It's a skin-derived anti-nucleoprotease. So it's actually known as SKALP. It's a skin-derived um, anti. SK is for skin, and this ALP is for anti-leukoprotease. So it's known as other name is also SKALP. So this is like a skin derived anti-leukoprotease. What it does is that it's actually isolated from skin and lung secretions, and this is it's actually a component of the epithelial barrier, which exists against the neutrophil elastase. So LFN is down regulated in the majority of breast cancer cell lines compared with normal. So basically, there are a lot of studies by in others also diseases, but generally it is need to be it is produced in the skin and in the lung and in the breast tissue, and it is and for skin because of its relationship with the skin GVHD, since LFN is overexpressed in cases of GVHD of the skin, and it correlates with the severity of the GVHD. So this is also used as a biomarker for skin GVHD in these cases. And the word that we have actually come across for this is that another word is LFN is actually a skin-derived anti-leukoprotease. So it's actually an inhibitor of elastase, you can say, which will occur in the skin, not only in the skin, but also in the lungs as well. So it is present in the uh, epithelial lining that forms the barrier. Now, the GI acute GVHD typically leads to secretory diarrhea. So, but nausea, vomiting, and diarrhea with headache. This diarrhea is mostly secretory in nature, and this can be copious in severe GVHD, and bleeding may also occur. So, not in the initially it may be watery, but then later on they could be mucoid and copious and foul smelling with bleeding, and also with blood stained diarrhea may also occur. And this differential diagnosis of this would then include, of course, not only the side effects of chemotherapy or drugs and infection of the GI tract, but and patchy involvement can lead to a normal appearance on endoscopy. So basically, when we come to the endoscopic findings, they may be missed sometimes because they could be a normal appearance on endoscopy. But a positive correlation has been demonstrated between endoscopic findings from intestinal mucosa and histologic bedding. So in the case of skin, the the findings would actually not have any relevance to the severity, or they would not actually add much to the prognostic part. But in the case of GI endoscopies, the extent of involvement of the GI tract would has just correlate. It has a positive correlation with the grading as well. So the biopsies taken at the endoscopy, they may show just patchy ulceration and progressing onto apoptotic bodies. There could be a patchy ulceration with apoptotic bodies at the crypt base. So in the skin, we had apoptotic bodies at the epidermal retipex, that is at the junction of the epidermis and dermis. Here we have apoptotic bodies at the crypt bases. So here the crypts basically uh, 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 the crypts are the ones that are affected. And there could be like actually a crypt ulceration and flattening of the surface epithelium. And just like just like the dermis had the lymphocytic infiltration, here also the submucosa would have some lymphocyte infiltration. In patients with symptoms suggestive of upper GI involvement with acute GVHD, upper GI endoscopy is needed. And but however, as we often lower endoscopic biopsy may also be helpful. So because both upper and the lower may be involved at the same time. So but in patients who underwent both upper and lower GI tract involvement, biopsy of the rectosigmoid was found to be the most informative. So then the imaging of the GI tract may reveal suggestive may reveal luminal and now not only the histological findings, but also the imaging of the GI tract may reveal luminal dilation with thickening of the small bowel wall. So in this case, the findings of on imaging are basically that we can not only there be luminal dilatation, but there could be thickening of the small bowel wall. So the wall is thickened and the lumen is dilated, and there are air or fluid levels suggestive of an ileus at that case. So at that point, basically because of the involvement of the neuromuscular tract as well, there could be ileus in that and at the point of involvement. And so even PET positron emission tomography may be helpful in the assessment of intestinal GVHD, and this could show mostly a lot of the soft tissue findings also. So in skin also they had mentioned that biopsies would not be effective for the prognostic or the grading part, but in the case of the imaging of this, but in case of the biopsies of the GI, they do support they do sort of guide the extent of involvement and regarding uh, the prognosis of there is correlation between this and the findings and the prognosis of the patient. But it is unclear whether we should go for biopsies, and you should not delay the management of the patient just to obtain the biopsies. So, however, biopsies may be helpful because they could exclude the alternative causes or coexisting GI pathologies in patients who do not respond quickly to first line treatment. Now, the liver GVHD typically presents with jaundice and cholestatic pattern of liver. So in the case of skin, we basically had the first the rash, and then there was this bullous formation and ulceration and of the skin, and then necrosis, then the toxic epidermal necrosis. In the case of the GI tract, we had the nausea, vomiting, diarrhea, and the diarrhea would first be just watery, then it would be like copious secretory, and then of course later on even a blood stain it could be even blood stain. Then in case of liver, it starts with the jaundice, And now this has a cholestatic pattern of involvement. So the liver injury, basically in the case of skin, it was basically the epidermal dermal interface, which was affected in the GI tract near the crypts of the intestine, and mostly they had mentioned that it would be upper GI as involvement also, but also the lower GI, especially the rectosigmoid junction which is involved. In the case of liver, the involvement is mostly in the gallbladder. So it's basically the gallbladder wall would be at the point of where the gallbladder duct actually opens and joins with the hepatic vein. So in the hepatic duct, so in that case, there's a cholestatic pattern of liver injury, which includes the because of which there is a elevated conjugated bilirubin. And so we have like this conjugated bilirubin, and alkaline phosphatase would be raised along with GGT, gamma glutamyl transpeptidase, which is raised. So this is the cholestatic pattern of liver involvement, and in this case, LFTs would be also of help, because we can see the conjugated bilirubin raised, alkaline phosphatase raised, and GGT levels are also raised. And also this ALT alanine aminotransferase has also been shown to be elevated. And this has been described in acute GVHD occurring after donor lymphocyte infusion, as well as in patients with acute and chronic GVHD. So this pattern of liver function derangement is particularly variable in children. So this is the part where they mentioned this difference between adults and children, that there could be in case of it has been described that acute GVHD can occur after donor lymphocyte infusions. So, and this can occur in patients both with acute and chronic GVHD. So, and the pattern of liver derangement is variable. Some children may not have this GGT level raised, or the alkaline phosphatase raised so much, or in fact, the alkaline phosphatase may be raised in children particularly due to age. So, there could be like variable presentation in children as to which of the markers of or LFTs are deranged. Now, the total bile acid and the cholesterol in the serum are also elevated, and coagulopathy with the hyperammonemia. So, all liver functions are deranged, and so they could be decreased clotting factors, and because of this, and because of their decreased clotting factors, and because of decreased excretion of the kidney, so hyperammonemia may also develop. And also the total bile acids and cholesterol in the serum are elevated. So there is bile acids and cholesterol are elevated. There is hypercholesterolemia, hyperammonemia, and coagulopathy with increased PTA. And the serum lipoprotein X, a non-specific marker of persistent cholestasis can become positive during evolution. So additional clinical signs of liver acute GVHD are painful hepatomegaly. So basically, in this case, we not only have jaundice, but because of the liver involvement, there would be this sort of there could be like pain at the site of the liver, painful hepatomegaly, and with the ascites and fluid retention, and then dark urine, especially the pale stools, because of the cholestatic pattern of involvement. So because as you know, the site where the bile duct actually the site at which the bile, the liver actually produces the bile. At that point, mostly this histopathological findings mostly occur. So at that point also, the patient may present with these cases of pale stools and dark urine. So non-specific symptoms such as fever, lack of appetite, and nausea are also common, and pruritus can also occur. And these were all, however, suggest some sort of liver involvement. So the differential diagnosis here is wide, and this could include veno-occlusive disease of the liver with viral disease, drug toxicity, and sepsis. So the histological findings can include endotheliitis. So histologically, if we go into the histological part of this, there would be endotheliitis with lymphocytic infiltration of the portal areas. So basically, it's the portal areas and the bile duct wall which will show destruction. There is bile duct destruction with pericholangitis. So all these areas actually blown up, and the lymphocytes will infiltrate then the portal areas. So if we compare it with all the other things that we've seen, we've seen these lymphocytic infiltrate also in the dermis, and the epithelium was, and the epidermis was showing the disc keratotic uh, features with the apoptotic bodies and all this ulceration. And then in the case of intestine also, we've seen that the dermis, the submucosa had this lymphocytic infiltrate with the crypts being blown up and apoptotic bodies at the base of the retipegs, and uh, actually ulceration of the crypts. And in this case also, the bile duct is actually destroyed, and there's pelychorangitis with the lymphocytic infiltration in the portal areas. So this is like there's like one area that's usually destroyed, and the other part it shows this lymphocytic infiltration. So there is a there could be this suggested that high levels of lobular inflammation and a low level of hepatocyte ballooning were also some favorable prognostic factors. Although iron overload and was also a sequel of previous. This could be because of previous blood product requirements rather than the pathogenic effect of acute GVHD. But this also was an adverse prognostic factor. So there are some associated favorable prognosis, like if you have low levels of hepatocyte ballooning and high levels of lobular inflammation. If the inflammation is high and no, and the this ballooning or the, this destruction was low, this was actually a favorable prognosis. And the adverse was actually iron overload if it occurred concurrently or simultaneously with the GVHD related to all the other pathological elements. So it in practice, it's often difficult to perform the liver biopsies, especially patients with thrombocytopenia. So also here also they found that this liver biopsies, they were not they should not be the diagnosis or treatment should not be delayed just to have this liver biopsy. In fact, now they've even gone for transjugular biopsies. So patients have even had not just percutaneous liver biopsies, but these transjugular biopsies, which were more helpful if you actually want to go for a diagnosis. Now, because of course we have this differential which is so wide, and this could include veno-occlusive disease of the liver also, and even viral infections and drug toxicity. So because of this close sort of differential with the with this, we would actually have a lot of overlapping factors. Now, historically, the acute GVHD can be described as occurring about before 1500 days post-transplant, with hyperacute occurring before neutrophil entrapment. So, hyperacute occurring within the first 21 days was the one which was used earlier. But now they have just divided it into the classical acute and the late onset acute GVHD. The classical occurs before 100 days and the late onset occurs after 100 days. And there's now this overlap syndrome, which has features of both acute and chronic GVHD. And basically, now the recommendations are that a transplant physician should be responsible for the supervising the treatment of patients with acute GVHD. And these clinical criteria should define acute GVHD and not purely the time post-transplant. So because we can have a lot of overlap between acute and chronic GVHD, the clinical criteria, they actually uh, they should define the acute GVHD. And we'll go into that once in a few minutes. In fact, this because this meeting might just end abruptly because of the 40-minute uh, sort of time limit that we have. So we'll rejoin again after 1 minute or so, and then we'll go through the grading part of this. So we've done most of the diagnostic part, and then we'll go to the grading part and of the acute GVHD, and then we'll continue. So I think we just have about 3 minutes left, so we could just wrap this up. That basically, an acute a transplant physician should be responsible, and the clinical criteria have been defined. And then there is this clinical diagnosis is appropriate if the clinical constellation of symptoms is present. So there should be this constellation of basically the involvement of the skin, liver, and the GI tract. This is what makes the clinical diagnosis more appropriate. If one of the if it's more like a skin involvement, or it's more like a liver involvement. So if it's more like a liver involvement, we'll have mostly a very high differential for veno-occlusive disease. If there's more of a skin involvement, the toxic epidermal necrolysis and those drug related toxicities would be more of a differential. And with intestinal GVHD, we could have like other differentials, including um, the presence of because of all the drug toxicities, and also the uh, presence of the effect of radiation or chemotherapy. So they could be also present side by side. So biopsies may be helpful if diagnosis is unclear, but they should not delay the management. So they have mentioned that biopsies can be helpful, but and they could only be helpful in grading of the patient. Now the grading actually is the Glucksberg system, and we have the Glucksberg system, and there's actually this modified Glucksberg criteria. So we'll be going through this also, the modified Glucksberg criteria, and at the diagnosis, extent of individual organ involvement in the overall grade, they should be documented, and because this would have and this not the extent of involvement would help not only in the grading, but eventually in the staging. So we have the criteria for grading and staging that we will go through. And I'll look this up in the Google as well. So there was some difference between the previous there's actually this EBMT sort of document that I was trying to open up.